Welcome to Concise Approaches to Internal Medicine. My name is Eliana Vázquez Cardona. I'm a fourth-year medical student, and today we're going to talk about the use of corticosteroids in chronic obstructive pulmonary disease. Before we dive into the use of corticosteroids in treating COPD, I'm going to highlight and remind you of a couple of key points about what COPD actually is. COPD is a complex lung condition characterized by chronic respiratory symptoms such as shortness of breath, persistent coughing, sputum production, and frequent flare-ups. These symptoms result from abnormalities in the airways and damage to the alveoli. These issues cause ongoing airflow obstruction, making breathing increasingly difficult over time. Understanding these basics helps explain the role of corticosteroids in treating COPD. COPD results from a combination of genetic and environmental factors interacting over a person's lifetime, a concept we refer to as getomics, gene, environment, and time interactions. While smoking is the leading environmental cause of COPD, exposure to harmful particles and gases from pollution also contributes. Additionally, factors like abnormal lung development and accelerated aging of the lung increase the risk. Overall, COPD arises from a complex interplay of genetic predispositions and lifelong environmental exposures. The key test for diagnosing COPD is spirometry. In the right clinical context, which we've just discussed in the definition and causes, spirometry is crucial. It measures how much air you can breathe out and how fast you can do it. If the results show non-fully reversible airflow obstruction, specifically an FEV1 over FVC ratio of less than 0.7 after using a bronchodilator, this confirms the diagnosis of COPD. Treating COPD requires a tailored approach focusing on the patient's needs and adherence to goal guidelines. Effective care includes proper inhaler use, managing symptoms like breathlessness and stress, and having a written plan for exacerbations. Regular follow-ups should monitor symptoms, comorbidities, inhaler technique, and risk factors. Physical activity is encouraged with pulmonary rehabilitation for advanced cases, and annual spirometry to track lung function for patients with coexisting asthma. Treatment should follow asthma-specific guidelines. The mechanism of action: the corticosteroids work by passing through cell membranes and binding to the glucocorticoid receptor, which regulates inflammation. This binding controls the expression of genes involved in inflammation and interacts with transcription factors like NF-κB. Additionally, corticosteroids reduce inflammation through non-genomic mechanisms such as inhibiting the MAPK pathway. While the cellular action of corticosteroids is understood, their primary target in COPD treatment remains unclear. The general considerations for inhaled corticosteroids: in vitro evidence suggests that COPD-associated inflammation has limited responsiveness to corticosteroids. In vivo data suggests that the dose-response relationships and long-term safety of inhaled corticosteroids in people with COPD are unclear. Both current and ex-smokers with COPD benefit from the inhaled corticosteroids use in terms of lung function and exacerbation rates. The GOLD guidelines do not recommend using inhaled corticosteroids alone in stable COPD, but suggest using them with bronchodilators. It's strongly recommended for COPD patients with a history of asthma or frequent exacerbations and blood eosinophil counts over 300 cells. It is weakly recommended for eosinophil counts over 100 cells. Its withdrawal is possible in patients with asthma or frequent exacerbation. In conclusion, its use commonly leads to mouth and upper way issues. Though they are usually not severe enough to stop treatment, its users have a nearly threefold higher risk of developing oral candidiasis due to reduced host defense, with fluticasone propionate posing a greater risk than budesonide or BDP. Additionally, it increases the risk of dysphonia and hoarseness, both of which are dose-related and may result from a steroid-induced laryngeal muscle weakness. This is the bibliography we base this presentation on, and thank you for watching.